So for those who have just joined us, I see a few more people are joining the call. Welcome. Today we are so pleased to share with you some of our greatest supporters and advocates, the huge impact that you have helped enable this year. Your support this year has enabled thousands of Australian families impacted by blood cancer to access care, information and support during what I'm sure we can all agree has been a very challenging year, especially for those most vulnerable. I'd like to thank you all for giving hope to families impacted by blood cancer through supporting groundbreaking research and helping us to advocate for the best treatments and outcomes for everyone, no matter where they live, their ethnicity, their background or their age. Today, we have brought together some of our senior leaders from across the Leukaemia Foundation who will share with you some of the biggest triumphs from the last year and how the challenges brought about by the global pandemic have made it possible for us to embrace new ways to evolve the care that we provide. So in today's seminar, we will talk about the achievements of the past year in each of the critical areas of our work. Providing best practice treatment and access to the latest trials, tests and diagnostics, providing trusted information and education to empower patients to make really informed decisions and choices around their care, and providing essential supportive care that improves people's quality of life as they experience blood cancer. We'll also touch on some of the priorities and actions that we will be working towards over the coming year. So without further ado, I'd like to firstly introduce our CEO, Chris Canty. Chris, some of you may have met in previous seminars, began his career in social work and for the past 25 years has held national and international executive positions, including CEO of Australia's National Disability Services and leading the well-known mental health organisation Headspace. Chris's career has been categorised or characterised by the creation of game-changing health services, in addition to extensive experience in strategy, service delivery and operational management. Most importantly, Chris has a genuine resolve to change healthcare for the better, and he is dedicated to improving lives and delivering lasting impact for the communities he works to serve. Chris joined us, I think, in February this year, and in that over the last 6 months has certainly stepped up to every challenge that has been thrown at him and has shown us he is an enthusiastic leader of both the Leukemia Foundation and the broader blood cancer community. Chris, welcome.
Thanks, Deb, and thanks everyone for joining us. And I'm glad to be joined by other members of the Leukemia Foundation who take turns in speaking to you. I just want to firstly thank you for the support that you've provided the Foundation over the years, but quickly acknowledge that I'm speaking from the Acute country, which is St Kilda in modern terms, and acknowledge the unique contribution of our traditional owners to our land and to our community. First Nations people loom fairly large in our strategy, and they loom large in our National Action Plan. I think we all know that sadly there is a considerable disparity in access to healthcare, not just in blood cancer treatment, but across the board in health. And it's an important area for action for the task force and for the Foundation. As Steph mentioned, the last year has not been without its challenges. Being in the middle of a global pandemic and having to pivot the way we provide services to people with blood cancer. So I wanted to take this opportunity to reflect on some of the highlights of last year and give you a sense of what the Foundation will focus on in the next financial year. But again, I'd really like to thank you for your contribution. This is the Leukemia Foundation. As Steph mentioned, I've been here since February this year, and it is clearly a very unique organisation with its history and heritage well planted in grassroots communities, largely in regional Queensland, but right across Australia, then growing to right across Australia. It receives very little government funding and relies heavily on its community support. And this is, quite interesting to me, who has worked for non-profits for a long period of time, but largely money comes through from government grants. This is a completely different way of thinking about the services we provide, and then on how we rely on that income on an annual basis to provide the support that we provide to people in the community. That support last year was sitting at around 5,500 Australians living with blood cancer, and we provided up to 22,000 support services during that time. And for me, coming into the organisation, it's a pretty extraordinary effort that all of that was made possible by the generous support of the Australian community. I also think it's especially remarkable in what was, by all accounts, a very unusual year, and going forward will continue to be challenging. To ensure the wellbeing and support of those we support, the COVID-19 pandemic required us to disrupt our long-established face-to-face service approach, again with challenges both to our clinicians and our patients. Again, your support helped us shift gears and pivot to a delivery of a combined face-to-face and digital blood cancer support. This approach has been really, really successful and importantly well received, so much so that we've established a digital support as a core service for people living with blood cancer. So we can reach even more people affected by blood cancer, and importantly, we can reach people anywhere in the country. It's clear to us that support in regional and remote communities is particularly important, and they're largely the communities that we have tried to service and provide accommodation. Importantly, our accommodation services continue to be fully occupied, and we move quickly to ensure compliance with strict infection control protocols, recognising that our clients are immunocompromised and that any outbreak would have disastrous consequences. We remain focused on providing the best quality of care to our patients in the mode that is determined by them and in a way that best meets their needs through all stages of their blood cancer journey. This year will see us focus more deliberately on patient input by employing a patient representative and establishing a consumer reference group to further expand on a range and breadth of services we offer. All of this means that we are using our best endeavours to reach patients wherever they are and through any channel that is most appropriate to them. If there is a benefit to operating in a COVID environment for the Leukemia Foundation and those we support, it is that it has enabled us to extend our reach and impact to people living in regional and remote areas who may be disadvantaged in terms of survival because of the limited access to best practice treatment and care. This is one of our biggest achievements this year.
Chris, I mean, you're clearly really passionate about our heritage, and many of the people on the call this afternoon know that our roots are really in rural and regional and Australia, and how important it is that we break down those barriers, be they geography or other access issues, to ensure that every Australian living with the blood cancer can access the best possible treatment and care. So thank you. Chris, you've mentioned briefly some of the numbers around blood cancer. Would you like to share a little bit more around the rates of incidence and how blood cancer is a growing problem in both Australia and globally?
Yes, Steph, I mean, this was one of the more striking things for me when I was coming into the organisation, and obviously I did my research, but there are more than 18,000 Australians who will be newly diagnosed with blood cancer in the coming year. That's 50 people a day, and that number is expected to grow, in fact, double in the next 15 years. Mm. These numbers reinforce, I guess, the significance of our support now, but also into the future, and being able to meet the changing needs of populations as they move, as we've seen, into regional and more remote communities. But the important thing, I think, in all of this is that blood cancer is the second largest, if you think about blood cancers combined, affect a significant number of Australians, but also take the lives of a significant number of Australians, more than any other. It's the second largest killer of Australians in all the cancer. So there's an extraordinary amount to do in this space, and I know the pipeline of research, and Tim will probably talk a bit about that later on, is promising. But there is a range of psychosocial supports that people will continue to need and use from our organisation into the future.
And Chris, with such a growing problem on our hands, what is the Leukaemia Foundation doing, or what have we been doing in the last year to really put blood cancer on the agenda?
Well, we've combined with the UK, New Zealand, the US, and a number of different countries to really raise awareness of blood cancer. And it's, we were talking earlier on that this is the last day of Blood Cancer Awareness Month, and it's gone very, very quickly. One of the big issues, I think, that we've recognised as an organisation is that people don't recognise the signs and symptoms of blood cancer, which largely can lead to delays in treatment. And one of the things that I've wanted to do since I've been here was really step up that advocacy and that early awareness raising, because we know the earlier that people get treatment, the more likely they are to receive a better outcome. So it's been a really important focus of mine, and I think a really important focus of the organisation. I think if we can educate the community more broadly, when you think about the four out of 5 Australians don't understand what the signs and symptoms of blood cancer are. If we can educate the community more broadly about those issues, then it's more likely that they'll attend their GP. I mean, this is incredibly complicated at the moment, and we know that people are delaying treatment. But if we can get people to their GP earlier and get them into treatment earlier, then the outcomes obviously
so much better.
So much better. And it's true in all areas of health. It's true in all areas of health, and but particularly true in blood cancer.
Absolutely. Early diagnosis is key. Chris, we do have one of the videos that was produced for Blood Cancer Awareness Month, which we'd love to share with everyone. It's just a couple of minutes, so we might bring that up now to show the collaboration that's happening with our peers in the UK, the US and Canada.
More than 1 million people are diagnosed with blood cancer around the world every year.
And around 700,000 people die from blood cancer every year.
But not enough people know what blood cancer is.
So this year, we've joined forces to take the conversation about blood cancer global.
Because 50 Aussies diagnosed each day is blood cancer.
And 3 Kiwis dying every day is blood cancer.
Every 23 minutes, someone is diagnosed with a blood cancer in Canada.
In the UK, it's the 3rd biggest cancer killer.
The 2nd leading cause of cancer deaths in the United States is blood cancer.
Leukemia is blood cancer.
Lymphoma is blood cancer.
Myeloma is blood cancer.
But they're just the ones you may have heard of.
In fact, there are more than 100 different types of blood cancer.
It affects people of all ages.
And blood cancer is the most common form of childhood cancer. This is Blood Cancer Awareness Month.
Please share this.
With your family, with your friends.
With everyone you know.
To help us raise awareness of blood cancer all around the world. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Wow, thank you. Thank you, Chris. Thank you for joining us today. We'll be sharing that video and how you can spread the message about blood cancer in the follow-up email after this session. I'd now like to introduce Tim Murphy. Tim is the General Manager of our Blood Cancer Partnerships area at the Leukaemia Foundation, overseeing our national research program and our advocacy effort. Tim, great to have you with us today. Thank you again.
Thank you, Steph. It's lovely to be here, and hello everyone. It's great to be with you again this year to tell you about the work we've been doing. As Chris said, during a very challenging time, we've managed to keep our focus and keep our support for people living with blood cancer, because that's paramount to the way we need to help people. What I'd like to do is take you through some of the research work we've been doing, and I know there's a slide going to come up now, which summarizes, last year was a challenging year. For everyone, and this year continues to be challenging. There's no two ways about it. But we made a very concerted effort in our planning as we were pivoting to manage COVID. Chris talked about the pivot to services through a digital format and telehealth. We maintained our investment profile for the research into blood cancer. The Leukemia Foundation is one of the critical funders in the Australian health medical research system, and we provide about 10% of all blood cancer research. So the money you provide to us, that you put into our stewardship, is very well spent. We did an economic assessment this year about the economic return on every dollar that was invested with us, and it generated a $5.90 return, and that is the leading metric in all of the medical research sector in the country for a philanthropic organisation. So we're really proud that we can work with you to find really important projects that are of high impact. You've heard me talk previously about our research program working on a number of levels. We support the ongoing development of talent coming into medical research through our PhD program. And we also do a range of larger scale impact programs. And they are primarily clinical trials and new research projects that look at the biology of blood cancer and new ways of finding targets and new therapeutic opportunities. So last year we were able to raise 1.98 million, just over that, into 37 projects, which is a really significant amount of money last year, given we had a downturn in the organisation. That money was leveraged by another 4.41 million, so nearly $6.5 million of research projects last year in a very challenging year. And the research went into disease areas of high unmet need. We have been very, very clear that we want to focus on the money that you give to us and we carry forward is designed to have high impact and support patient need. And so we've been looking at projects that deal with subpopulations of the major disease types and some of the smaller disease types, as you'll see there on the slide there. The lymphomas, leukemias and myelomas continue to be the largest diseases by incidence. Therefore, we still have to keep doing further research to manage survival rates, but a lot of the work has gone into sub-diseases within those broader diseases. And we also focus on the smaller incidence blood disorders as well, MPN, amyloidosis, and MDS. And I'll come to the GVHD in a little while, Steph, to talk about the GVHD program that we have with the Garvin.
Tim, would you be able to share maybe a little bit more detail about some of the specific projects within our research program that were invested in last year, with thanks to many of the people who are on the call this afternoon?
Of course. One of the things that we developed 2 years ago now was the Centre for Blood Transplant and Cell Therapy program. It's a multi-site consortia across 5 different sites in Australia and 2 US sites. And that program is looking at improvements in stem cell transplant programs. And one of the major challenges of stem cell transplants is when a patient receives the cells from somebody else, because that's what a transplant is about, your body can reject those cells. And that is called graft versus host disease. it can be very, very debilitating. So we purposely invested in this consortia to find new ways of repurposing existing drugs or finding new clinical trial processes that would diminish the likelihood of GVHD. We are seeing some top-line results, which are really exciting, and hopefully by end of 22, that clinical trial will be fully able to report to the public on improvements in clinical practice. And that's the major thing we're focused on, is clinical practice change, not just basic science or fundamental science, but clinical practice change. There are two other things.
Tim, can I just stop you there for 1 minute? I've just noticed a couple of people are actually on the call this afternoon who have directly supported that particular project. So I would just like to acknowledge those families who have, I know, been touched by blood cancer and who have seen value in investing in that particular program of research. Graft versus host disease is not something we hear about every day. It's not well known, but the impacts on families and patients can be really devastating. And I think that's, you know, a $1 million investment that we've made in that program over the 5 years is extraordinary. And that's only with thanks to the generosity of people on the call today, but in particular, those families who are with us today. A special thanks to you for allowing us to invest in this important program.
And you're absolutely right. And by having this patient-focused approach into the investment, we're able to increase the scale of the project. We're able to increase the number of patients enrolled, and we're able to fast-track aspects of it that otherwise would have taken longer to establish. So these are really, I get a tingle down my spine, because we're having impact, and that gives me reason to get up every day. And knowing this is such a hideous consequence of a stem cell transplant, that if we can find ways to minimize it, we need to do more. The fight ain't done yet, unfortunately. And that's the nature of research. You know, we've seen fantastic advances over the years in new therapies, new treatment modalities, but we've come to this point in time where survival rates haven't improved universally for every single subtype. So I showed you on my last slide so groupings of blood cancers, but we know in fact there's about 120 or 140 discrete subtypes based on understanding genetic profile. And that's where a lot of our research is now being directed to, is understanding the particular drivers of your genetic makeup and mutations. And so there are two programs that we're also supporting, creating a new class of drug to treat myeloma and T and B cell non-Hodgkin lymphomas and acute myeloid and lymphoid leukemias, all designed to attack discrete types of blood cancers. So the effect on the patient will be less toxic and more targeted.
And Tim, I'm aware we're doing some work also in the area of childhood leukemias. Are you able to share a little bit more detail? I know there's a few key projects we're working on in that space. Are you able to share a few more details?
Yeah, there's one project that I think we haven't really talked about much, and I think it's a really important one. And this is the precision medicine we're doing for young children with Dr. Michelle Henderson. And as I said before, we've seen some significant increases in survival rates. However, for some subtypes, and particularly with AMLs, survival rates are still about 30%. That's where we were in the 80s. So the science hasn't taken us further yet. And I say yet purposely because the focus is now on addressing these disparities. Chris talked about disparities in access to treatment. We're talking about disparities in access to research that's focusing on these subpopulations that haven't got the 90 or 80% survival rates. So Dr. Henderson is a senior scientist at the Sydney Children's Cancer Institute, and she's targeting certain subtypes of AML to understand why they have such a poor prognosis. And she's found there is a particular chemical entity. It's a biochemical called nicotinamide adenine dinucleotide, and I'm going to call it NAD from now on. And a little bit later on, I'm going to talk about the NAP. So we're not going to get the NADs and the NAPs mixed up. But this NAD protein is a driver for cancer cell growth. So if we can, so what Michelle's doing is targeting a response on to turn off this action of this protein. So it's basically a stop sign to stop it working. Rather than energizing the cells, we're going to turn it off. And she's found that that process of stopping cell growth means the cancer doesn't continue on, and it can actually be treated with other types of chemotherapy treatments. So it's a really interesting advance in understanding the particular drivers of how that particular cancer has grown.
And how will that research go to next, Tim? They've made this great discovery, Michelle and her team.
Well, there'll be yeah, there'll be because it's at clinical end. We think there may be the ability to change clinical practice with current therapies, or there may be a new drug developed. It's still unclear, and we'll see how that comes again when they report back to us fully at the end of next year. But excellent. It's very, very promising.
I mean, what's really heartening about just some of the updates you've shared this afternoon is that this has all happened despite COVID, which is really extraordinary. I know we've had some delays and setbacks, and researchers have adapted to, you know, changed working conditions, as many of us have. But I think it's really extraordinary that we've been able to maintain and in some cases increase our commitment to these researchers who are working tirelessly to try and find better ways to treat, to diagnose some of these really tricky blood cancers, which, as you say, we haven't made as much progress as we would have liked to in the last 15 to 20 years.
And that's the nature of science. We have to keep investing. And, you know, everyone who's involved in this disease state is committed to advancing care, from the support and care we do for people at the bedside, as well as the development of new therapies and treatments. And it's unfortunately not over yet. The job still hasn't been finished. And last year's COVID and this year's continuing pandemic, as I said, we have to focus on our health and our well-being in spite of the external challenges we all face. And as Chris said, 50 people a day are diagnosed. That's not good enough.
There's more to do.
Much more to do.
Tim, you've touched on clinical trials, which, as we know, are the pointy end of research where patients really get access to the discoveries and the breakthroughs. Can you talk a little bit about our current investments into clinical trials and perhaps how that's been impacted over this period?
It's interesting in blood cancer that clinical trials are actually standard of care. So for some people, the best possible treatment is the newest treatment. And kind of the new treatments leapfrog over the previous standard of care. But the only way to get access to that new treatment at the moment in a timely way is through a clinical trial. And particularly where we have deeper and deeper understanding of the genetic makeup of your disease, a clinical trial could in fact be the best way of getting access to treatment. Now, that's very different to when we think about experimental drugs that are in a traditional clinical trial sense. A lot of what we've been doing here is repurposing existing drugs to be reapplied in a new setting for a new disease, or expanding an international trial into Australia. Because whilst we're 25.5 million people in the South Pacific, we're a long, long way away from the major markets of the world. So the investments that we've been able to do have been about bringing arms of international trials into Australia so they could open here, as well as expanding a new trial that we've developed with Tool to Cure, the blood cancer genomics trial, which is a really fantastic initiative around giving people who, quite frankly, are at the last option. It's called Salvage Therapy. And the thinking behind this is find a way to understand the genetic makeup of that person. So we do some tests on them and then match their genetic profile with an array of anti-cancer drugs. So in fact, a breast cancer drug could serve the purpose of someone with AML because of the genetic makeup. And by doing it in a clinical setting, we're able to capture the data, and the lessons learned from that experience can be applied to the next person who has a similar experience. It's a policy change, it's a strategy change, and it's a really unique way that the Australian marketplace can provide ways for patients to get access to the best possible treatment for them when they wouldn't normally get it through the traditional PBS system, which can be a bit slow when it comes to precision medicines in this way.
I think this is the jewel in the crown, so to speak, Tim. This is a project that many of you will be aware of. We've been talking about for 2 to 3 years. So that is the timeline. That is one of the timelines around research. It's taken 2 or 3 years to get this up and running. Pleasingly, we welcomed the first patient to the trial only a couple of months ago, and really pleased to share, if you haven't heard the news, that the team leading the trial was successful with securing a significant government grant to expand this trial so that more Australians in almost all states will eventually have access to this trial across a variety of disease subtypes. So a really special one, and one that, as Tim mentioned, was very well supported by our funding partner, Acute. So a big thanks to them for leading the way and making that investment alongside the Leukaemia Foundation.
It was a brave decision done well, I say, in saying that we can bring our resources to bear to direct at the inception a new idea that no one else in this country was doing. And because we had passionate donors, passionate researchers, we were able, as the intermediary, bring them together. And I'm incredibly proud of this one, because it will change people's lives. Absolutely. We don't see that. We haven't got the data yet. Again, there's another one where I think next year's update is going to we'll have a much more real life examples rather than hoping to be, but it will. Absolutely confident that this will change the course of people's lives who actually didn't have options, and that's the design of this.
And I think what's also really exciting is what you've said earlier, is that this is about bringing clinical trials to Australia, because we hear time and time again that people go in search of international trials overseas. We've heard cases where drugs have been developed in Australia and they've had to go offshore to access them. That shouldn't be the case. And if anything, COVID has shown us that we need to do more of this here in Australia, and
we have a great partnership with the clinical community through the Australian Leukemia and Lymphoma Group, ALLG, the clinical trials group, and also the professional association, HSANZ. And both of those groups have been instrumental in the planning, the development of both and the support we provide to them around expanding the clinical trial program.
They're an excellent partner. Look, I can see that we could talk about research all day long, Tim, one of my favourite areas, and I know a lot of the people on the call today both have personal experiences with blood cancer and have been big supporters of our research program, but I do want to allow time to talk about a few other areas of our work.
I'll see you soon.
I'll come back to you shortly to talk about advocacy. Just a reminder, if you do have questions for Tim, for Chris, for any of the upcoming speakers, please pop them into the chat and we will endeavour to answer them towards the end of the session. But right now I wanted to jump to Will. So I'll just ask someone to bring up a slide about Will. So this is Will. Will was 29 when he received his diagnosis, I think at 11 p.m. at night, telling him to go straight to the emergency room. And at the time, Will and his family weren't sure what was going on, which is a common situation that many of our blood cancer patients find themselves in. Will was later diagnosed with a blood cancer known as acute lymphoblastic leukemia. And this diagnosis came just a year after marrying his wife, Sarah, who's pictured on screen. Fortunately, Will's haematologist was running a clinical trial at the time, and Will gained access to that particular trial. The trial involved 9 months of intensive chemotherapy and then 2 years of chemotherapy following the trial. Will and his wife being 29, were considering having a family, and his doctor at the time said it could take potentially up to 7 years for he and his wife to conceive naturally. So as part of his pre-treatment workup, his sperm was collected, but fortunately, really pleased to share, and you could probably tell from the pictures here that Sarah ended up falling pregnant naturally, and this year Will celebrated his first Father's Day with baby Leo, who's pictured on screen here. What followed the birth of his son here is that Will knew he had to get on top of his mental health for both himself and his young family. So he reached out to the Leukemia Foundation and was able to access some counselling sessions at no cost to help him process his experience and everything that he had been through on his treatment journey. Will decided to share his story with us today because he really wanted to help other young people, particularly young men who have been diagnosed, to know that having a family is possible, and that whilst blood cancer can take a lot from you, you can still have the life that you want to lead after it. Will was going to join us today, but unfortunately wasn't available. But I did want to take a moment to thank Will for allowing us to share this story with you today. It reminds me just how important the services that Leukemia Foundation provides are for people living with blood cancer, in addition to the research and giving access to clinical trials, which are also obviously critical in keeping people living well after blood cancer. I'm now really pleased to introduce you to Andrew Smith. Andrew is the head of People Living with Blood Cancer, overseeing our support services area. Hi, Andrew.
Hi, Steph. How you going?
Good.
Lovely to be here.
Thank you. Thanks for being here. We just heard from, well, we didn't hear from Will, so we just heard Will's story this afternoon, who highlighted just how important the care and support is right through someone's blood cancer journey, from diagnosis, during treatment, and beyond. Can you talk a little bit about the support that your team are providing to blood cancer patients and their family, particularly during this difficult year that we've all been experiencing?
Yeah, absolutely, Steph, and a big thank you to the invite to speak to everybody on the call today. And I do want to also acknowledge, I know there are some of our supporters who also have lived experience of blood cancer, and that is really, really important to acknowledge. And just sort of touching on, you know, Will's story and hearing the statistics of blood cancer, which you and Chris spoke about earlier in the conversation. You know, all of those 50 new diagnoses that happen each day have a story behind them, just like Will's, and it is you know, really a privilege to be involved and to lead a team across the country that does provide that vital information, that practical support, that emotional support that you know Will has been accessing. It's a real privilege to be able to do that for our blood cancer community. You know, we've been doing this for over 45 years, and excuse me, as you know, as everyone's mentioned on the call, the last 12 months has been, you know, a really significant time for our patients and our families with the pandemic. But as we know, cancer and certainly blood cancer hasn't stopped, and all of the usual information needs, all of the practical needs, all of the supportive care needs, the emotional, the psychological, the practical needs, they haven't stopped either. And the team has been really wonderful at embracing the opportunity to find new ways to connect with people like Will, given some of the challenges that the pandemic has placed on our healthcare system as a whole, and our community in general.
And potentially will continue.
And 100%.
Place pressure. How have the needs of blood cancer patients changed over this period, Andrew, from the experience of the blood cancer support team, who are, for those of you who aren't aware on the call this afternoon, we have a team of about 30 blood cancer support coordinators who are largely health professionals who provide a variety of support services to help people navigate and deal with the impacts of their blood cancer. So yes, Andrew, just curious to hear how have the needs of patients changed over this period?
Yeah, absolutely. And sort of touching on what Tim was mentioning before in his discussion around the research community adapting to changing circumstances. You know, we early on in the pandemic, we certainly were getting feedback and data from our teams about what were some of the themes, what were some of the changing needs of our patients and families during this particular time, and we were really cognizant of making sure that we were not slapping together programs or resources, that everything that we wanted to do had a solid evidence base, and we certainly went out to our community very early on with some clinical research, and some of the findings from that research were quite stark, and probably for me one of the most stark findings from that research was about 35% of our patients that we surveyed were experiencing clinically significant psychological distress, so high levels of distress, and when compared with pre-pandemic time and pre-pandemic research, that's double the amount of psychological distress that our patients and carers were dealing with, and the team had to adapt to in a swift way. About a quarter of our patients were reporting significant unmet needs during the pandemic. Almost everybody surveyed in our research, reported clinically significant distress and worry around fear of their cancer coming back, their blood cancer coming back or progressing. Some of the data showed us that the groups that we were most concerned about were people that were younger. So younger, like Will, people living in regional areas, which we've also mentioned, and then people that had significant financial toxicity, that were worried about the effect of the pandemic on their family finances or on their job as well, and about a third of our study participants from that research said they'd lost income during the previous 3 months of the pandemic. So we really wanted to make sure that given those changing needs, that we were meeting those needs as best as possible, both last year and ongoing into the future.
And how have we done that over the last sort of 12 months, Andrew? Are you able to share some sort of highlights of the support that's been provided?
Yeah, absolutely. I think we've got a slide we can bring up just to show some of the raw, I suppose, the raw numbers. So over 5,500 Australians provided with one-to-one support, and as we previously mentioned, our ability to connect face-to-face with people has been significantly reduced because along with abiding by all of the public health guidelines, we wanted to make sure that we were putting the safety of our patients and families first. You can see a huge amount of people that thirst and need for reputable information. So 411,000 people accessing our website for cancer information. 733 families provided with accommodation close to our treating centres. 392 people used our new transport program. 344 attending online support and education groups, and this is somewhere that's continuing to grow significantly for us, and will continue to grow in the next 12 months. Nearly 600 people supported with financial assistance, and over 22,000 interactions from our blood cancer support coordinators to those 5,500 Australians living with blood cancer.
Some big numbers there, Andrew, and a reminder of just how important and critical some of these services are for helping people to manage and deal with the impacts of blood cancer. So thank you to you and your team and for being with us today and sharing some highlights from your year. I'm now going to come back to Tim, if we can bring Tim up, so to share a little bit more around what his team have been doing in the blood cancer advocacy space. Tim.
Thanks, Steph. As we've talked about over the years, the efforts that the Leukemia Foundation has been driving to not only pivot to changes in service delivery and not only in funding further research, we've taken a much larger leadership position around the 0 lives lost to blood cancer goal by 2035. Over the last 2 years, in our last couple of conversations, we've talked about the creation of the State of the Nation report, which was the first time we got an evidence base for the actual scale of blood cancer in this country. We're now, blood cancers, when they're brought together, are the second highest by incidence and mortality, which is, well, we're not shopping for cancer, but it's a damning number. And it means we've got to change the policy settings around how we service people who are dealing with blood cancers, because it's effectively a series of over 120 different rare cancers coming together as disorders of the blood. So there are some real issues around how we can, with the whole blood cancer community, with the health system, with the governments of this country, find new ways to improve support for people who are dealing with the trauma of a blood cancer diagnosis, so they get access right across our country to the best possible treatment and care. So if you're in Mount Isa or in Broome or here in Adelaide where I am, you get the same standard of care. And unfortunately, what we found in the State of the Nation report is that is not consistently applied at the moment. So we know we have to do that piece of work first to get standards set that are clinical standards and applied across the country. We're not criticising the way the system operates, we're saying it could improve by being more consistent.
And Chris, and Tim, how can people get involved in supporting this advocacy effort?
So we've been very much talking about the work we've been doing with the Blood Cancer Task Force to create the first ever National Strategic Action Plan for Blood Cancer, the National Action Plan, the NAP. I talked about the NAD before, now we've got the NAP. And the NAP is a plan, a very tangible plan to reform the way we deliver care. It's about empowering patients, making sure we have a pipeline of new treatments and investing in research for the treatment of the future, as well as improving the way the health system actually operates. So the plan has been established. Minister Hunt launched it in September of last year during Blood Cancer Awareness Month, and we've been working very busily this year on implementation of the first steps, the first actions of the action plan in the creation of the standards that I've talked about. And the first step of those is a thing called optimal care pathways, which are written documents to guide clinical practice and the expectations of a consumer or a patient of their clinical practice. It doesn't go to the full detail of if you have AML and your second line treatment is, that is what comes next in the work that we'll be doing next year as we implement the next stage of the action plan. The challenge we face though, Steph, is the community that we are working with is a community that is increasing its public profile. Blood Cancer Awareness Month and the work we've been doing has been raising profile of blood cancers, but it hasn't necessarily meant it's translated to the level of support from governments and other parts of the blood cancer community that we would like. So we want to continue to raise the profile of blood cancer, not just during Blood Cancer Awareness Month, but continuing on through the year and into next year on a new public awareness campaign called Set the Standard. And that campaign is designed to solve for the challenges we've identified around the disparity in survival outcomes between different parts of the country. And we know that today, if we had the standards in place and they were consistently applied, and Australians across the country got access to best possible treatment and care, we could save 1,375 lives. That's 1,375 Australians who, because of where they live, because of their financial circumstances, because of a whole raft of access challenges, they don't get access consistently. So that's why we want to put in the standards around clinical practice and access to treatments and make that consistent across the country. So the campaign itself, Set the Standard, is asking our community of concern, so the people on this call today and the rest of the donor community and the supporters of the Leukemia Foundation, to sign up to our campaign, to register their concern and say, we want collectively to raise the profile of this issue and convince decision makers to continue to work with us to implement the standards. The campaign itself is very simple at this point, and we're showing you today the first glimpse of it. We'll be publicly launching this campaign after Light the Night on the 18th of October, in a couple of weeks' time. It's kind of bizarre that we're at the end of September, but here we are. And the campaign is very straightforward. We ask people when they go to the website, put their name in and register with their postcode. And when you do that, a gorgeous green heart of concern pops up on the screen of Australia. And what we're wanting to achieve is the whole map of Australia to be populated with these green hearts, and the tally of how many thousands or hundreds of thousands of Australians who support this campaign will be able to demonstrate that level of community concern to the decision makers in Canberra and their state capitals. As a community group, we have a responsibility to keep raising the profile of the issues around blood cancer, and the world that we live in now is very, very complicated, and there are lots of reasons where decision makers don't have a lot of time. So if we can help raise profile, do it in a way that is designed to support the lived experience of people currently with the blood cancer, but to progressively get better, then I think we've got a very tone positive, supportive campaign that shows that there's a community of interest and a community of concern who wants to see the action plan implemented in full quickly. And that's the purpose of the Set the Standard campaign. I believe that'll be circulated to the people on the call today.
It will. We would absolutely love for everyone on the call today to add your name to that tally, and we will share details in the follow-up email to this session on how to do that. Thank you, Tim. Wonderful to hear that you're making some headway there in the advocacy space. Now, look, that brings us to the end of our formal update. Just another call out if anyone does have questions, to pop those into the chat, and we can direct those to the most appropriate person on the call to answer. Tim, I did have one question in the meantime while people are adding their questions to the chat, just around, I know a key part of your work is working with the various bodies to get drug listed on the pharmaceutical benefits scheme. Would you be able to touch on what involvement the Leukemia Foundation has had over the past year in bringing new drugs to market and providing affordable access for patients?
The process is a very it's called the Pharmaceutical Benefits Scheme. It's a funding line from the Department of Health, and it's administered through a group called the Pharmaceutical Benefits Advisory Committee. Effectively, learned people talking to each other about the value of a particular drug. What has happened over the last few years is the voice of the lived experience of patients and the value that people see in new therapies has been included in the decision making in a more substantive way. We have been one of the leading patient voices and have been actually on a pilot program to modify the way in which the lived experience is brought into the decision making. And we've been very pleased that we've been able to through our advocacy and through our connection through Andrew's team, find out exactly how a new therapy will affect someone's life, and we can then tell the decision makers why it's valuable above and beyond the benefits to the health system or the benefits to the hospital, what it means for that person who, because it might be an oral therapy rather than IV, they don't have to go to the hospital once a week. And therefore their life gets freed up and they may be able to walk more. And those things don't necessarily get included in the traditional assessment process, but by bringing the lived experience in a much more cogent way, it is having an impact. And we've just seen recently that the medicines industry and the government has signed a new 5-year agreement. And in one of the elements of that agreement is further reform in how the patient lived experience is included in government decision making. So that's a really good reform opportunity, and we will be continuing to advocate for further understanding of what it means for an individual and their carers, and to make sure that that lived experience is built
into the process.
Yeah.
And that, Tim, from a patient perspective, if drugs are listed, that can obviously lead to an extraordinary saving in terms of the amount of money that they're required to spend on their treatment. I think last year it was 5 or 6 drugs were listed with thanks to our advocacy work and bringing in that lived experience and the patient perspective into the process.
This government has made a very a strong commitment. About 3 years ago, it said any therapy that received a positive recommendation, it would list in a timely manner. So that we've really been concerted in making sure the lived experience gets included in the decision making, because the government said if you get a yes, it'll fund it. And so Minister Hunt has been, and the government has actually spent a lot of money on new therapies, and that's a really good thing.
Good thing for patients.
Really
Well, thank you, Tim. I'm just conscious of time. I haven't seen any further questions come through, but if you do have questions after the session, please feel free to reach out and we can respond to those directly. So I'd just like to finish by saying thank you again for your attendance today and for making all of the amazing work that we've heard about today possible. It's only with thanks to your support that we will achieve our shared goal of 0 lives lost to blood cancer by 2035. Over the coming days, you will receive an email with a link to join the Set the Standard tally, along with a copy, if you haven't already received, of our 2021 Leukemia Foundation Impact Report. You may have already received a copy of this, but there's further information about the impact that you've helped enable in that document. I'd like to finish by thanking our speakers, Chris, Tim and Andrew, and also Will for sharing his story with us today. That brings us to the end of our session, but if you would like to get involved or have questions, please get in touch. We'd love to hear from you, and would also like to mention a couple of dates that are coming up. Please mark your diaries for Light the Night on Saturday the 16th of October. And also in November, we will have another supporter seminar on the topic of precision medicines and clinical trials. So once again, thank you all for your attendance and for your ongoing support. I look forward to connecting with you soon. Thanks again.